session is Dr. Sudhir Sapkota. Dr. Sapkota is a pediatric oncologist currently working in Kanti Children's Hospital. After completing of his pediatric hematology.
Sorry, yeah. Dr. Kisaga, just to sir. I think we have got Krishna Bista sir online. He will give the welcome speech. Yeah. We have got him. He's available.
Sorry, this webinar on introduction of pediatric palliative care is hosted by Nepali Association of Palliative Care with the association of NEPAS, Nepalese Society of Pediatrics. So I would like to welcome Dr. Krishna Bista, President of NEPAS, Nepal Pediatric Society, and is a consultant in Kanti Children's Hospital for the welcome speech. The floor is yours, sir.
Mute. Hello, is it audible?
Yes, yes.
Thank you. Thank you, Dr. Krishna, for giving me chair. So it's my great pleasure to welcome you all in this important webinar. Webinar on pediatric palliative care, more care and less agony. So I would like to thank Nepalese Association of Palliative Care for organizing this year. We are living in COVID era, and so we are in, the world is on uncertainty and stress. So in this period, the child are also feeling like that. So, and at this time in Nepal and India and other parts of, or we have problem with landslides and flooding. So we are losing our population, losing our people by this flood. So I want to talk about palliative care. Palliative care is palliative care in adult and children is different. So we are in expanding phase in palliative care in Nepal. So we have very few development in palliative care in pediatric population. So we have a good webinar on this session, and we have faculties from international and national. So I would like to welcome you all, and I hope this will help Nepalese children to get good care and other care in this COVID era and in difficult situation. I will welcome you, and the floor is yours, Dr. Krishna Sagar. Thank you.
Thank you, Mr. Sir, for your kind introduction and welcome speech. Pediatric, really, we are in the very initial stage in the palliative care in pediatrics. There is much was already done in adult, and we are the very initial phase to develop pediatric palliative care. So, Nepalese palliative care with all the interested group, all from the expert from the awards, we are trying to establish the pediatric palliative care in Nepal. So I want to introduce Dr. Sudhir Sapkota. He is a consultant pediatrician and hemato-oncologist working in Kanti Children's Hospital. After completing his fellowship in hemato-oncology and bone marrow transplant, he is a keen interest to develop the pediatric oncology as well as palliative care in Nepal. He is working as a consultant in Kanti Children's Hospital and faculty of the NAMS, National Academy of Medical Science in Kathmandu. So the floor is Dr. Sudhir to introduce the pediatric palliative care.
Thank you, Dr. Krishna. Am I audible?
Yes.
Okay.
Yeah.
So is the slide visible? Yeah.
Yes.
Thank you. Thank you, Dr. Kisakar, for this kind introduction. So without losing any time, let's start with the introduction about the pediatric palliative care. So we might be wondering as a child what this pediatric palliative care actually means. And so I hope to give you a glimpse of what this pediatric palliative care is. So I'm Dr. Sudhir Sapkota, and this talk will cover about the pediatric palliative care. What is it? Who needs it? Who delivers it? When to deliver? where to be delivered, and why we want to focus on children. WHO definition of palliative care, I have broken down into different points, and it states that palliative care is an approach that improves the quality of life. So everything, whatever we do, should focus on improving the quality of life for both the patients and the families. So both the patient and families will work as an integrated group. For those families and patients who are facing the problem associated with life-threatening illnesses, it may be any form of chronic diseases. And how will you do it? We'll do it by preventing and relief of suffering by early identification, assessment, and treatment. So what will we identify and treat? It is the pain, and not only the pain, the other physical, psychological, and spiritual aspects. So to summarize, the WHO definition consists of to improve the quality of life of both the patient and families who are suffering with life-threatening illness, and we want to prevent it, and we want to relieve the suffering by early identification and assessment and treatment of pain and other problems. And in this, we have seen the picture of Cicely Saunders. Actually, she is the one who has started the movement for hospice, and all this whole idea of palliative care, the credit of this idea goes to Cicely Saunders. Now coming to the aims of palliative care, it is always an interdisciplinary approach, and this care is provided and services should be coordinated by various departments and units, and it should be the patients, families, palliative care providers, and other non-palliative healthcare providers should collaborate and communicate about care needs. And it can be given with when the potentially curative treatments are still going on. So palliative care and curative care, these two are not mutually exclusive. In fact, they can go parallelly side by side with each other. The other main aim of the palliative care is that the desire for peace and dignity of the patients and families should always be respected and should be supported during the course of illness, during the dying process, and even after the death of the child. As I mentioned, it is going to be an interdisciplinary service. So we'll go for the hospice palliative care team members or the palliative care team members, where there are volunteers, nurses, physicians, pharmacists, dietitians, counselors, and all of them will work around the person and the family caregivers. So what will they work? They will work as a holistic approach, and they will try to give the care support to the family and the caregiver. They will also go for the symptom management so that there won't be any suffering. Along with that, we should give the nutrition support to the child. That should be counseling should be done, and spiritual care should be taken care of. And the financial issues, if there are any, should be tried to sort it out. And finally, we should coordinate it and put the child on follow-up. So we have got multidisciplinary systems who are working together to provide a holistic approach to the child. Now the next question is, when to give the pediatric palliative care? During the course of illness, after screening or the diagnosis has been made, the curative care starts, and at that time, right at the time of the diagnosis, the palliative care should also be started. The only difference is that when there is active disease-directed treatment, the intensity of curative care is more and the intensity of palliative care is more. However, in case of chronic disease, with the progress of the disease, when there is minimal disease-directed treatment, we will increase the intensity of palliative care and with the decrease in the curative care. And moving forward, when there is no any disease-directed treatment, in that case, the curative care will end, but still the palliative care will go on and will continue with the end-of-life care support. And even if the child dies, the palliative care moves on with the bereavement support to the family. So palliative care should begin at the time of the diagnosis, and we should not think that the palliative care starts only after the any disease-directed treatment has stopped. So palliative care and curative care should always go hand in hand. Now we are talking who needs the palliative care. These are the 4 diagnostic categories for the children who need the palliative care. The first one is the life-threatening conditions for which the curative treatment may be feasible but can fail. There are some conditions like advanced or progressive cancer or cancer with a poor prognosis in which treatment is available, but there is no certainty that the treatment is definitely going to cure the child. In such cases, and the other examples are complex and severe congenital or acquired heart disease, trauma or sudden severe illness, extreme prematurity. The second category is the conditions where early death is inevitable, where there may be long periods of intensive treatment aimed at prolonging life. So in this case, we should institute the pediatric palliative care to bring the normal activities in the child and to maintain the quality of life. The examples are cystic fibrosis, severe immunodeficiencies, if you are not going for the transplant, and human immunodeficiency virus, chronic or severe respiratory failure, renal failure, and other myopathies and neuropathies. The third diagnostic category, which requires pediatric palliative care, is the progressive conditions without any curative treatment options. And in these cases, actually the palliative care is exclusive. We're providing exclusive palliative care, and this may extend over many years. Examples are progressive severe metabolic disorders and certain chromosomal disorders like trisomy 13 and 18, and severe osteogenesis imperfecta subtypes. The fourth diagnostic category is consists of irreversible but non-progressive conditions. These conditions are like severe cerebral palsy, prematurity with residual multi-organ dysfunction, multiple disabilities, and other severe malformations like anencephaly. These diseases are non-progressive and they lead to complex healthcare needs leading to complications and likelihood of premature death. Going to the statistics, this is the data where we can see that the lower middle income and lower income countries contribute about 80% of the need of the pediatric palliative care. So the disease, the burden of the disease and the need for the curative treatment is high in our setup. Along with that, the need of the palliative care is also high in our setup, and we should be focusing not only in the curative treatment, but also in the palliative care. So this is on the data from the Global Atlas of Palliative Care. In this, we can see the distribution of children in need of palliative care at the end of life by disease group. And in this, we can see that the congenital anomalies consisted of 25% of the cases, neonatal conditions 14%, and the other cancer consists of the almost 6%. So this data shows that the need of pediatric palliative care is more in case of children with congenital anomalies, neonatal conditions, malnutrition. So only the cancer is not the disease requiring the palliative care. So this is a summary of the study by Feutner, and this we can see that the most common primary diagnosis as seen in the earlier slide. Again, we have got the most common disease was genetic and congenital causes 41%, neuromuscular 39%, and malignancy 20%. The second, going to the second and third point, the medical technology use, we have seen that in 80% of the patients, there was some form of intervention done as a part of the palliative care. For this, feeding tube constitutes 60%, central line 22%, tracheostomy 10%, and 9% of them were ventilator dependent. The other point is mean number of medications. They have been using 9.1 medicines in each child. So what we can take from this slide is that we should be using medical technology. We should be deliberate in using more and more medical technology and number of medications for the treatment of child with palliative care, but it should be there to improve the quality of life and not only to prolong the suffering or to increase days to the child. So whatever technology or the medications we use, it should be there to increase the quality of life of the children. The other is the components of the palliative care. many of the times we focus only on the physical symptoms like pain, cough, tiredness. However, in addition to that, there are other psychological factors like worries, fears, sadness, and there are social needs, needs of the family, issues of the food, work, housing, etc. And there are special concerns that need to be addressed, and like the questions of the meaning of life and death and the need to be at peace. Regarding the second point of psychological, there are worries, fears, this should be addressed for both the child and the family. And if the parent, if the mother is sad and gloomy, we won't expect that the child will be happy being cared by a gloomy father or a mother. So the psychological aspect of both the children and the family should be addressed. Now the next question is, who should deliver the pediatric palliative care? Pediatrician with training in palliative care definitely would be the best one to deliver the service. Alternatively, we can go for the palliative care physician. We have got some training in the pediatrics. However, in our setup, both are in short supply. And talking about the large, well-resourced centers, they have dedicated multidisciplinary team who work for the pediatric palliative care. Regarding the palliative care model, the universal services should be provided by all the general practitioners, and it should be incorporated at the level of education or play group. And if the child needs more of palliative care, the core palliative care services should be provided by the community nursing teams, hospice, bereavement service, and the sibling supports. And if the needs of the child are even more, we should go for the specialist palliative care service, and this is usually provided by the tertiary specialist pediatric care and symptom control. And this all should be taken care of. Actually, one people should be in work as a focal person to take care of all these services. So, though this palliative care model is an ideal one, in our setup, we don't have all these facilities. So, every healthcare worker can, and actually every healthcare worker should give some palliative care. Make use of what and who is available. We should not wait for a pediatrician. We should not wait for a palliative care expert to come and give the palliative care to the child. We should always make use of whatever is available with us. So there is the way to give the palliative care. Even in the hospital setting, like outpatient clinic or daycare clinic, where the children will come, counseling will be done, their symptoms will be assessed, and they will given medications, they will play, and then they will go home. If the child is more sick, if the child needs intravenous medications, then the child can be admitted in the inpatient setting, or the child can be admitted in the hospice if he has if the child requires the end-of-life care support. Similarly, in clinic setting also, it can be hospital-based or the community-based. The third setting is the home setting, and definitely for the child, home-based palliative care team can be provided, and it will be the best option for the child, because the child always wants to stay in his bed and he wants to enjoy the privacy of his home. But we will always be shortage of human resources to provide the home-based palliative care team. But if available, this will be the best one.
So last 1 minute remaining.
Okay,
so
sir. So what are the peculiarities in children? Why do we want to focus on children? Because they have got this right to education. To go to school is like a normal behavior in the children. And in case of feeding terminally ill child, the mother always wants to feed the child. So small bouts of feeding should always be given, and it should preferably be the choice of the child, unless and until it is contraindicated. And the other thing is that since the child is physically and emotionally increasing, if you're counseling a child at the age of 5 years, as the disease progresses, when he reaches 10 years or 15 years, his demands and his problems have drastically changed over time, and we need to. The other thing is the peculiarities in children are this respite care. So the respite care, it provides short-term relief for primary caregivers. We don't want burnout of the mother. many of time what happens is that parents forget their own basic needs when they are looking after the children. So respite care should be provided. It can be arranged for just an afternoon or for several days or weeks. And it can also be provided at home in a healthcare facility. It's always preferable to provide respite care by the family members. And if there are any family members, the father or mother should be substituted by healthcare professionals, and healthcare professionals should be available to give the respite care. So this brings into my talk. So what are the take-home messages? We should focus that the palliative care includes addressing physical as well as psychosocial and spiritual concerns for the child and even the larger family. The palliative care can and it should start at the time of diagnosis, and it can be given along with the curative treatment. The palliative care is not just for children with cancer. As we mentioned, other life-limiting or life-threatening conditions should always be included. The last but not the least is the palliative care can be provided by many different healthcare professionals. All of us can provide some form of palliative care, and it does not always require the specialist. So palliative care is everyone's responsibility, not only the responsibility of the specialist. Okay, with this, I'll come to the end of my slide. So if we have a happy child, we will have a happy family and a happy. So let's make the child happy. Let's make the society happy.
Thank you, Dr. Sudhir, for your nice presentation about the introduction of pediatric palliative care. You have cover very well. So our time is 15 minutes for each speaker. So I just try to remember all the panelists to stick on the time and 15 minutes. So you are within the time. So I want to move to next sessions, a component of palliative care. So I introduce Dr. Gayatri Palad. She is my mentor in Hyderabad. So she is globally well-known palliative care physician based in Hyderabad. She is instrumental in setting up pediatric palliative care in MNJ Cancer Hospital. She is part of the Two World Cancer Collaboration and play a key role in research, education, mentoring to set up new palliative care, not only in India, beyond India, in Southeast Asia, and she is a well-known teacher for most of the palliative care health worker in Nepal. So many of us are working in different centers in Nepal. So I want to welcome Dr. Gayatri. The floor is yours, madam.
Thank you very much, Dr. Krishna, for the kind introduction, and good morning to all of you. It's a great initiative which you have taken up. I congratulate all the organizers and the participants who have joined. Dr. Sudhir gave a very nice foundation for our discussion forward. Beautiful overview about pediatric palliative care. What I'm going to do is that elaborate a little more into going into the details of components of palliative care, picking from where Dr. Sudhir left. Most of what I'm going to say is based on recommendations and standards set by organizations like American Association of Pediatrics, European Association of Palliative Care, and American Hospice and Palliative Care Association. So it's not my view, it's just a standard set by many international organizations. And I'm going to take a case study to understand a little bit more, going into deeper part of the components. Next slide. So this is a patient who we saw in our community program. I've changed the name, Jadhav. He was born after prolonged labor, did not cry immediately, developed seizures and required prolonged hospitalization. They were delayed milestones, both mental and physical. The parents took the child to many hospitals, even to a special school because of all these issues. Finally, they gave up and they just resigned to fate because nothing was helpful for them. Next slide. The child, when we saw him, he was a 14-year-old. He had difficulty in walking. He had very painful conditions in multiple parts of the body, a lot of contractures, very poor hygiene because he had poor toilet training. He was passing stool and urine just like that, speech and hearing impairment, aggressive behavior and tantrum, no social skill, very minimal social skill. He had two younger sisters going to school. If you see that it's there in the picture, they were embarrassed because of this kind of behavior by their older brother, and they were very upset because children would make fun of them and their brother, so they were very upset about the whole thing, what was happening. Jadav's family parents were farmers. They used to go to field to work, and the child was left alone, unsupervised. He would just wander around the whole village, and it was becoming a problem for them. And as he was going bigger and he was reaching adolescent, they were finding it very difficult to handle, and they requested us, can you put him in some home? Next slide. I can see that all of you can relate to this example. We see that child with life-limiting illnesses often have complex and multifaceted needs. Next slide. And because of which they need continuum of care over the time across the spectrum of their support and different settings at their preferred place of care. I'll just say next when I please then move the slide so that I can focus on what I'm saying. Sorry about that, Chuck. I thank Chuck and Dr. Sudhir for helping with the slide sharing. Yes, and if you see the components of who needs palliative care, so it is the special needs of the sick child, parents, siblings, and also for the health workers who are providing care to such kind of family and children. Because when we are providing, it's a lot of stress for the health workers. So it is also about us. So that makes the whole the team the core part of component of pediatric palliative care. Next slide. What are the minimum standards of a pediatric palliative care team? When a team is looking after children, they say the team should have a multidisciplinary team. There should be seamless transition between settings. When the child moves from hospital to home or to a nursing home or a hospice, the transition should be seamless. There should be one consistent caregiver. Within the team, there should be one person designated who will look after the child, a link forming between the family and the hospital. And ideally, because these children, they need long-term care round the clock, there should be availability of assistance 24 hours, 365 days a year, because issues are often complex and they develop a lot of crisis. Next slide. And the multidisciplinary team, which is looking after those children, they should have the expertise to address the physical, psychosocial, emotional, and spiritual need of the child and the family. Next slide. Dr. Sudhir showed this triangle. Most of us are, if you see, we are at the tip of the triangle, the yellow part of it. The child, say for example, Jadav, when initially he developed problem, all the workup happens in the specialist hospital and a lot of treatment happens, and then the child and the family at some point of time are told, nothing more can be done, go home. Then child goes to the base of the triangle. He goes home and he is in the community where he's connected with the school and his play group, siblings, and other support system. The middle part is where the child goes to when the child needs help. They go to the nearest general practitioner or any community health service which they have. But the child moves between these three parts of the triangle. This is what we call it as pyramid of pediatric palliative care services. Next slide. So when you talk about pediatric palliative care, especially when you're talking about, suppose you're in a hospital now, what does it mean? They say that pediatric programs serve patients in perinatal, infancy, childhood, adolescence, young adulthood, and survivors of pediatric diseases. So they are the group of people who may require pediatric palliative care. Next slide. And the hospitals which are planning to start pediatric palliative care, they must have policies and procedures in place to address all the dimensions of care to all of these children. Next slide. When you're looking at the profile of the children, what we have to understand, I'm talking about now a very restricted part of hospital-based palliative care. The child, often they have restricted mobility because of their disabling conditions, and often they have more than one caregiver Why I'm mentioning this is because most of the hospitals, they don't allow caregivers. But if you're planning a pediatric palliative care in your hospital, there should be provision for the family to be with the child. Next slide. So typically a hospital palliative care setup should have easy accessibility, access to trolleys, wheelchairs, and the family members to stay. Next slide. Play is a very critical component of child's growth, development, and expression of feelings. So even if it is a very basic, they should have designated play area when you're planning a pediatric palliative care. Next slide. We are going to discuss a little more at length about these issues, but this is definitely, it should be there. All essential medicines, including opioids, should be available when you're planning a pediatric palliative care service. Next slide. Dr. Sudhi spoke at length about this integration. They say early integration, whether the outcome is going to be cure or death or not getting cured, whatever the outcome, they should have the early integration of pediatric palliative care. Next slide. Now, this is a picture which shows very clearly what it means. The child and the family, from the day one, they should have this option to choose both curative and palliative. It should not be one or the other. Both should be together. So the choice should be given to the family and the child to choose both. Next slide. And the services which we can offer through pediatric palliative care, what is that we do? Often I am asked this question. Pediatricians, they say, we are already taking care of children. What is that you do differently when you are talking about pediatric palliative care? If you look at it, the different components, pain and symptom control, end-of-life care, psychosocial and spiritual support, play and school, rehabilitation, bereavement support. These are the different things which we offer as an extra layer of support to what the core team is already doing. Next slide. We are going to discuss the one component of symptoms, which is pain, in detail, but generally the recommendation is that assessment and management of distressing symptoms are fundamental in maintaining and improving a child's quality of life. So symptoms can be many, but all the symptoms, there should be a system to systematically address the distressing symptoms and address in terms of assessment and management. Next slide. Again, we are going to discuss this in the subsequent sessions. There should be open and clear communication between the healthcare providers, child, and the family. If you see, I mentioned the child, the communication with the child, and with the objectives of discussing treatment options, shared decision-making, and the choices which they have to make, but taking into consideration their individual preferences, values, and cultural beliefs. So we are going to discuss this again in detail. Next slide. They also recommend that when you're working in the hospital, the hospital is encouraged to partner with the community, the local schools, social service agencies, government aids, healthcare agencies, faith groups, other services, so that we provide that continuity of care wherever the child is moving, so that the child gets this support and care. Next slide. In the hospital, if you are thinking about pediatric palliative care, they say that there should be comprehensive, timely, accurate clinical record in standardized format, which are age appropriate and unique to pediatric population. Wherever you are providing service, whether in the community or in the hospital, age appropriate, standardized, there are enough standardized format there for symptom assessment, communication, and other aspects that should be available. Next slide. Yes, the child dies and the families, they grieve, and that's where the bereavement support starts. Child is not supposed to die, a child, because that's not nature, that's not natural. But when the child dies, the parents never typically get over the loss. It's very distressing to the family and when they lose the child. Next slide. So bereavement support should be an integral part of our program if you're planning pediatric palliative care, because these families are very high risk for complicated grief. The griefs can be normal and complicated, and they're very high risk for developing complicated grief. The family needs a lot of support after the death of the child. Next slide. So excellence in pediatric palliative care is essential for all hospitals and facilities caring for children. Any facility dealing with children, they should have some understanding and support in terms of palliative care. Next slide. And next slide. What they say is that to achieve that, all general and subspecialty pediatricians, family physicians, pain specialists, pediatric surgeons, they should all learn basic principles of pediatric palliative care. Then only we can offer, whichever facility the child is moving, they get some basic palliative care support. If only these people, they have some training in pediatric palliative care. Next slide. So what is that the minimum they should know? This is the recommendation again by American Association of Pediatrics. The minimum recommendation they should say that all residents, fellowship and CMAs should include topics. Suppose you're organizing a conference in pediatrics, have a component of pediatric palliative care and think about discussing these components of pediatric palliative care. The concept of palliative care, pain and symptom management, communication skill, grief and loss, managing prognostic uncertainty, how to decide forego life-sustaining medical treatment and advanced care planning, and spiritual dimensions of life and illnesses. So things, core component which every pediatrician have some understanding and support. Next slide. So put it all together. This is a picture I've taken from National Hospice and Paliative Care Association organization. The child, the family, in the community, they are the core part of pediatric palliative care, and they should get essential medical support, spiritual support, and psychosocial support. And that support they should get in the continuum as the entire state, their journey of their illness till they, as long as they live. And it should be done by interdisciplinary services. Many disciplines should come together to give that kind of support. And across the setting, wherever the child wants to be, most of the time the child wants to be in the homes. So if home is the place where the child wants to be, they should get the care there. And it should be wherever they wish to. Very important that when we're providing care to the child and the family, pediatric palliative care, the team should have necessary training and education. Anybody cannot do it. Even the volunteers who are involved in the care of the child, they should have some basic training in pediatric palliative care. There should be enough research because very less is known about pediatric palliative care. So enough research should be there going alongside with your program. And quality outcomes, because we're constantly thriving towards the best practices available and improving and providing the best of care to our children and the families. So we constantly work towards improving the quality of the care. And most important, because today we are at the threshold where they're just beginning to talk about pediatric palliative care. Advocacy becomes a very critical component, which is what your team is doing right now today. So many people, I see so many participants today have joined, 50 participants. Or today what we are doing is the advocacy. I'm sure 50 of you, when you go back, you are going to talk about pediatric palliative care. With that note, I end my presentations and take questions if there are any. Thank you.
Thank you, madam, for your nice coverage of component of palliative care. So I will take the questions in last, maybe we'll respond question in the chat session also. So without delay, I want to invite Dr. Vishnu Datta Paudel. He is a president of Nepali Association of Palliative Care, professor and director of DM Medical Oncology. He is one of the recipients of first South Asia Palliative Care Award. He had taken important role in production of morphine, oral morphine, and availability in most of the hospitals in Nepal. He is a principal investigator of NCI supported international study for mobile app for pain management, and he has several palliative care related articles in Nepalese and international journal. Not the least, he is my mentor, not only my oncology, also in the palliative care. So he is going to address in the pain management pediatrics. The floor is yours, sir.
Thank you, Dr. Kishan Sagar. I'm audible?
Yes, sir.
Yes.
Okay. First of all, I'd like to thank all international speakers and friends and my NEPCare friends for making this possible. And I apologize for a slight delay also. Next slide. Next slide. Next, should I send that? Okay. So the objectives of today's talk is we'll talk a little bit about the pain in the children and how to assess and the interventions what can be done. As we know, the pain is the most common symptom found in the adult as well as children suffering from life-threatening illnesses. And to treat pain efficiently, we have to know how pain has started, what are the types of pain, and so types of pain is basically classified best depending on the duration, how long it is there, and how the pain is produced on the best of the mechanism. Like we call it acute pain when it is a very brief duration, which goes away with healing, usually 3 months or less. Example, when there is a broken bones, when there is a cut by the knife, and the operative pain, those pains are acute pain. And chronic pain is a longer duration of the pain, which persistent or recurrent pain lasting beyond the usual course of acute illness, injury, or more than 3 months. And in palliative care, we are mostly concerned with the chronic pain. And pain is also divided based on the mechanism, nociceptive pain and neuropathic pain. Nociceptive pain is a pain which is due to the stimulation of the nociceptors. Those are the pain receptors, ending of the pain receptors at the peripheral surfaces. And neuropathic pain is the pain due to the damage to the nerve, because this classification is essential so that we can properly manage pain. Now, the assessment is very much essential for every symptom until and unless what is the baseline we cannot treat. So like if the child has a fever, the mother complains the fever, we measure it and we give the paracetamol, and after that again measure it. Likewise, pain also has to be measured. For pain management also, the thorough history has to be taken, like when it was started, what is the provocative factors, what is the relieving factors, what is the quality of pain, like is it a burning pain, stabbing pain, like that, where is the reason, and what is the severity, whether it is a mild one or a very severe one, and the time of the pain. Now, there are different scales which is used to measure the pain. That's one popular, which is mostly used in the adults and the children who can speak and communicate well. You can use the numerical pain rating scale, where there is from 0 to 10, 0 means no pain and 10 means maximum pain. And we have to ask the child who can communicate and where is his pain. So if he points to 1, 2, 3, then it is mild pain. If he points in between 4 to 6, then it will be moderate pain. If he points from 7 to 10, then it is a severe pain. There are other scales. The most economical scale, the most universally available scale, the scale which you can never forget, always carry, is our own hands, 5-finger scale. Like we can call, if you have a little pain, 1 finger, more pain, 2 finger, more pain, 3 finger, maximum pain, 5 finger. So like this also, we can measure the baseline of the pain. And there are other scales also, like a faces scale, where we have the numerical scale as well as the facial expression. And quite important in case of a pediatric is a flat scale. The letters, each letter stands like F stand for the face. You see the facial expression, whether the child is smiling or withdrawn. You see the leg activities, whether in the normal position or restless. A stands for activity. How is the child activity? Normal position, or it is a very rigid, jerky position. And C stands for the cry, whether the child is crying or no cry or mourning. And the last C stands for the consolatory, whether the child is relaxed or whether you can hug and make the child relax, or it is difficult to console. So on the best of these 5 characters, we can again score. So after we know the child has a pain and we know what type of pain it is, and we know the scoring, then comes the management of pain. And pain should be managed in a total pain management. It's not only that we just prescribe the analgesic, just take this tablet. We have to talk with the child, we have to listen to the child's psychology, and we have to listen to the parents also, the social background and the spiritual background, and try to manage totally. Basically, pain is managed in a two way. One is a non-pharmacological management, another is a pharmacological. And there are several non-pharmacological management which can relieve the child pain. It could be the drawing, it could be the music, or sometimes applying heat, or sometimes applying cold, or there are other like a physiotherapy, TENS. So different methods can be applied to relieve the pain of the child. And when you go to the pharmacology, there are medicines available to relieve the pain. Basically, the pain medicines are categorized into three categories. The number one is opioid analgesic, number two is a non-opioid analgesic, and number three is adjuvant analgesic. The most important, the group of drugs which is important in the pain management is opioids. And from clinical point of view, opioids are generally classified into two groups, strong opioids and weak opioids. Strong opioids, it's a morphine and fentanyl. Weak opioids, it's a codeine and tramadol. In adults, sometimes we may use codeine and tramadol, weak opioids, but for children, pediatric, we don't recommend it. We don't use weak opioids. We use only strong opioids. Then the morphine, the drug of choice for moderate to severe pain. This is a very important medicine. It's a wide therapeutic range. You can start from the minimal dose and you can go on ranging. There is no dose limit. The sky is the dose limit. You just have to watch on the side effect, whether the child gets any side effect. So with a tolerable side effect, you can go on increasing the dose. And it is effective by different routes. You can give by the mouth, you can give by injection, you can give subcutaneously, you can give intravenously, and relatively it is expensive, inexpensive, which is not very expensive. And in some of the hospitals, we provide it free also. And the most important point is that it is available. In fact, in Nepal, all forms of morphines are available. Now, when we talk about the oral morphine, it's acts in the opioid receptor, mu receptors, and kappa. And when you give the oral morphine, plain releasing morphine, the peak effect comes after 1 hour, and generally it is repeated after every 4 hours. At the bedtime, you can double the dose. And when the pain is controlled with the plain morphine, later on you can convert into the long-acting morphine, into the BD dose, twice daily. So there is a table to show that which form of morphine start at what time and peaks what level and where and what is the duration of morphine. So as I said before that morphine is available in Nepal, morphine tablet 10 milligram morphine is available, morphine tablet prolonged release, sustained release 10 milligram, 30 milligram is available, morphine injection is available, morphine syrup is available, which is 2 mg per ml. And in fact, the first morphine, oral morphine, which is available was a morphine syrup. It was launched in 2009 because of considering the children, because it is difficult to take tablets for the children. So let's start the production of the morphine with the syrup one. So we started with the syrup production. And then came the tablet in 2011, plain tablet. And then 2012, we produced the sustained release, prolonged release tablet, morphine 10 milligram and morphine 30 milligram. I personally feel happy that I also contributed to some extent to make this morphine available in our country. So the dose of morphine, as I said, you can start with the low dose. If it is an oral morphine, plain morphine, you can start with a 0.2 milligram per kg. It has to be started 4 hourly, and as needed, if the pain is not controlled, you can go on increasing the dose. Just you have to watch the side effect. And another important thing we have to understand is that there is something called breakthrough pain. If a child gets a pain in between the 4 hours, then also you can give the extra dose of the same dose which you are giving 4 hours, which is known as the breakthrough pain. And IV morphine, you can use 0.05 milligram per kg every 34 hours. But we have to understand one thing, that when we are switching from oral morphine to IV morphine or IV morphine to oral morphine, the dose is not the same. At least it is IV morphine is, when you are converting, it has to be half, or better to say 1/3. So that point has to be considered when we are changing from oral to IV or IV to oral. Like all other medicines, opioids and morphine has also side effects. The most common side effect is constipation. We have to ask always, how is the bowel habit? And in fact, we have to prescribe side-by-side laxatives also. And the other common side effects are nausea, vomiting, urinary retention, itching, rashes, dry mouth, and respiratory depression. Respiratory depression is not very common. It's very rare when you start from the low dose and slowly increase. But we have to be careful, and we should keep emergency of the naloxone, which is the antidote for the respiratory depression by the morphine. And
1 minute, 2 minutes, sir, for you to wrap up. 1 minute to wrap up the session, sir.
How much?
1 minute, sir.
Okay. The other group of drug is a non-opioid medication. We are generally using, so I don't want to go detail, this is paracetamol and NSAIDs. And the third group of drug is the adjuvant medicine. The adjuvant drugs are used primarily to treat for other conditions, but may be analgesic in selected circumstances. The example are steroids like dexamethasone and gabapentin, pregabalin. So these are also used. So these three groups of drugs we can use in the management of the pain. And finally, I want to end my slides that basically we have to follow the WHO 2-steps approach. That if the child is suffering from mild pain, then we can manage it with the NSAID and paracetamol plus minus adjuvant. And if the child is suffering from moderate to severe pain, then we have to give morphine. In summary, pain is common in children, but undertreated. Assessment is very essential, and we have to tailor the treatment to the pain and severity and the child. And morphine is the drug of choice for moderate to severe pain. Adjuvants are useful, and we have to anticipate side effects also. Thank you.
Thank you, sir.
Yes.
Thank you, sir. Very nicely well covered the pain management in pediatrics. So there is no words to explain more than what you have taught in your lecture. So I would like to introduce next speaker, Dr. Spandana Raila. He is a pediatric palliative care consultant from Hyderabad who works with the Hyderabad Center for Palliative Care. She is interested and engaged in research, academic, teaching, clinical works, and advocacy, not only in India but beyond that in Southeast Asia. She had the lead. She is working as a part of Indian Academy of Pediatric Pain and Palliative Care chapter. So she is going to talk about the communications scale and communication in the pediatric palliative care. The floor is yours, Spandana.
Thank you, Dr. Krishna. I think, Chuck, can you help me share the slides? Sorry. In the meanwhile, I just want to say that communication is something we teach or we discuss a lot in palliative care training. It usually takes somewhere around 6 to 8 hours to cover the whole depth and breadth of the topic. And even then it sometimes feels inadequate. And to say that I'm going to cover all of it in 15 minutes would be a huge overstatement. But I think this is where we can start thinking more about it and have a discussion. Regarding communication, one other thing I personally feel is pediatricians and people who work in pediatrics are more adept with it compared, personal opinion again, more adept with it than other specialties. I think it's more because we have to talk to very anxious parents, and we start doing it most of the times by seeing from our seniors or doing it ourselves. And uh, here is more about talking to people and families with life-limiting and life-threatening conditions. Next slide, please. So why do we even have to communicate? We are just doctors or nurses. We can do our work and go away. But we do have to realize that developing a partnership and providing information are a huge part of giving treatment. And also to have a care plan, have good to discuss about the treatment options and what could be the different outcomes and the management of the outcomes. To have all this, we need to communicate. And sometimes people need to know what is going to happen in future. That is the one thing they're so worried about, and that gives them a better idea. And also to understand what is their idea, what are they hoping out of this, and what are their expectations. So to have all this, we need to communicate with the patients and their families. Next slide, please. So one thing we have to remember, especially when we are communicating with children, is that they have three languages. The first is the verbal, the ones that we use with our words. The non-verbal, which takes a huge part of the communication, that is our body language, the signals we are giving to them by the posture we sit in, the way we talk, the tone, the pitch, the frequency. So all these come under the non-verbal part. And I think the much underutilized way of communication, because we are all busy giving the medical treatment, is the play. So play is a way children communicate and they express their feelings. All this comes through play. If you see this little girl, she is receiving treatment, she's uh, going through a lot of uncertainties and new things. But even then, she would appreciate the opportunity to play. And while play, she can share much more better than just making her sit in a chair and speak. Next slide. So there are a lot of myths that we have when we go to work. We think that young children do not need to know what is happening to them. That little kids, they're only 6 years old. Why do they have to know that they have cancer? And we also think that children can adjust quickly just because they're not showing what is happening with them. We think that they're well adjusted. And people also say things like, oh, they're so lucky that they got cancer when they're a kid and they recovered. If they were adult, it would have been so much more. And again, I think this is something we extend to all aspects of our life, that we shouldn't talk something that makes a child cry. We shouldn't share with them something that hurts them. An active playing child does not have worries. We think that just because a child is playing around, running around, that in the background of their mind, they have any worries. And children do not worry as much as adults. Again, thinking that they're playing, they're eating, they're having fun, we think that, again, that they don't think as much as us. And this is a protective statement, I believe, that children are better off not knowing. They can keep playing, they can be happy if they don't know the truth. So these are some things that we think. Next slide, please. So especially when we talk in the context of palliative care, where we are talking about life-limiting and life-threatening conditions, where the quality of life is decreased and death can happen prematurely. So should we even begin these conversations with these children? I want you to take a moment here and think, if a child is in your care and they are close to death, or even if death is possible in the next 1 year or 2 years, would you consider discussing this with that child? A 6-year-old child, a 10-year-old child, a 12-year teenager, a 16-year adolescent, would you consider? Next slide, please. So this has come up in Journal of Clinical Oncology, and it says that because children know when they're dying and they can sense extraordinary stress of their parents and doctors when death is imminent, they may feel tremendous isolation if they're not given permission to talk openly about their illness and impending death. So this journal is saying that children want to know, and if they want to know, we have to share information. Next slide, please. So what are the advantages of disclosing difficult news, including death? Are there any advantages sharing such terrible news with a child? Next, can you click once? Yeah. So when we start sharing information that is difficult, that is considered bad because it changes their view of their future, it is still, there are definitely advantages out of it. The first thing is that it helps in open communication. Because we are honestly communicating, we can also help them cope better with giving them other skills. And by being honest, we are strengthening the family dynamic. So the parents are not hiding anything from the child. And it's also important in relationship building. In palliative care, because we are through them, through their whole journey of their life and sometimes their death, it's very, very important that we have a good relationship. And also, it is important to know the timeline for the child and the family so that they have time for memory making and creating legacy. So this, I mean, it can be a small party that they can have with the family or a get together. It can be a vacation they always wanted to take, or it can just be, you know, cooking a dish the child likes and having the time. So memory making can be multiple things. These can be pictures, these can be videos, but all of this can be discussed or brought to the forefront of a discussion only when we even start having this discussion around death and what can happen. Next slide, please. Can you click one?
Last 1 minute, please.
Okay. Can you keep clicking? I just want to go forward. So every child's needs are individualized. And I just want to share a story. So once to my OPD, there was a little girl who was referred, a 13-year-old, not so little actually, and she had a recurrence of rhabdomyosarcoma. That was my first interaction with her. She was referred from an outside hospital, and I was asking the parents what do they know about her condition, and they requested me if we can send the child out of the room. And I said, definitely, my nurse will show the child around the hospital. But the child said, no, I want to stay here for the conversation. She was assertive. And I said, okay, what do you want to talk about? I think she just needed someone to ask, what is it you want to share? And the moment I asked that, that little girl told me that she knows she's dying and that she's going to die very soon. So I asked, okay, how did you come to know? Who said this to you? And then she said that because her parents were crying all the time, she left the phone recorder on and left it during a conversation between the parents. And she came back and played it for herself. And she came to know what the parents spoke. And because no one was giving her the opportunity, she couldn't even say that, I know that I'm going to die. So she was waiting for that window. And I think that is something we all have to provide. And the slide shows that 100% of parents who spoke to their children about what is going to come were happy about it. And there were a lot more parents who did not want to talk about it. And there were a certain percentage, not a lot, but if you think it is a lot, 27% regretted not talking about it to their child. Next slide, please. So these are the 5 C's usually children want to know. They think, did I cause it? They think that their cancer is because they have been a bad child or because they hit their brother at some point. And sometimes they wonder, can I catch it or can my family members get it from me? And they worry that if I play with my brother or sister, they can get this condition from me. And they worry about it. Can it be cured? And who is going to take care of me is one thing that they think a lot about it. And a lot of times kids, when they realize that they're dying, they have this separation anxiety that they have normally. So they're like, okay, if I die, I go into the ground, but how do I sleep next to my mother? So how do I listen to my mother's lullaby? So they worry a lot about it. Dr. Krishna, do I have time or do I have to wind it up?
Thank you, Spandana, for clear presentation how to communicate with the child. So I would like to invite next speaker, Dr. Megan, about palliative care in COVID-19. Megan is a pediatric palliative care physician based in Ottawa, Canada. She has extensive experience working in developing countries, Southeast Asia, and especially in Bangladesh. She is the director of Pediatric Palliative Fellowship in Hyderabad. She has led multiple online projects to capacity build for pediatric palliative care in Southeast Asia, and she is one of the best person अथवा persons to start pediatric palliative care in Nepal, our mentor, our guide regarding development of pediatric care in Nepal with the collaboration of Tool Canada. The floor is yours, Dr. Megan, please.
Thank you very much. And I am so pleased and excited to be part of this pediatric palliative care session for Nepal. And I think it's a wonderful, wonderful opportunity. I'll just speak very briefly about pediatric palliative care in the setting of COVID-19. There's many things we could say. There's now like 5,000 articles on COVID published. I've summarized a few of them for us. We'll talk about two things: the children who are infected with COVID, especially the children who have serious illnesses like the ones that Dr. Sudhir mentioned who need the palliative care and how we give that, and a little bit children affected by COVID, which overlaps a bit with how Spandana talked about we need to talk to the children, we need to involve them in care. There's a bit of a busy slide, I apologize, but we know overall a few facts about COVID. There's lower rates of infection in children. We have some studies looking at the whole town of Vo in Italy, which showed that there was no children under 10 who were positive, despite 2.6% positive in the whole town overall. So less numbers, although we are seeing bigger numbers in India these days. It seems that transmission is lower, so children are less likely to transmit COVID to adults from some preliminary data. But again, we don't have big, robust studies yet. And a significant portion of children, 13 to 32%, do not appear to develop any symptoms or have very mild subclinical symptoms, just mild conjunctivitis, mild respiratory or cough or fever. But then there's the other end where we have 0.6 to 1% of children who have severe COVID infection. Although this is a small number of children, but deaths do occur. And I would draw your attention to this reference, which is excellent, which is updated every week, where a group of doctors in the UK, pediatricians, summarize all the new COVID evidence about children. And every week I check that and get the newest updates. The clinical features of COVID, very briefly, you can see them listed here: fever, cough, and respiratory symptoms. Occasionally GI symptoms and rash. And it looks like any other childhood viral infection. It's not distinguishable in any particular way in many cases. We also have these case reports of this multi-system inflammatory syndrome, which seems to be a delayed immune response to COVID, as sort of similar to a Kawasaki shock type situation. Most of those children have been reported to recover, but there have been some deaths. Now let's really turn our focus to the children who need palliative care. We call them the children with the serious illnesses, pre-existing serious illnesses. We know from data from Italy and China especially, and now emerging from the US, these children are slightly at an increased risk of being hospitalized or needing to go to ICU, especially for children who have respiratory, cardiac, or complex neurodisabilities as their underlying condition. But remember, these children already at baseline have a higher risk with any respiratory illness. A child with cystic fibrosis or congenital heart disease is definitely more at risk for RSV, for influenza, for landing up in the ICU or hospitalized with those things. So COVID is no different. A little bit more data. There are about 10 studies now looking at children with serious illnesses, and here's 2 that I thought were most relevant for us. In New York City, they looked at 174 hematology or oncology patients who presented to 2 large hospitals. They were presenting for routine care like chemotherapy, transfusions, etc. 11% were positive. 11 children out of 19 were hospitalized, including, as you can see, some who needed significant care, intubation, ICU, and 1 child died. That was a child with sickle cell disease who apparently had no previous significant history of complications, but we don't have more details. In Italy, again, similar type study, 286 children with cancer presenting for routine oncology care, 7% were positive and no deaths. 2 children had some mild to moderate respiratory issues. But at the same time, despite the fact that COVID may not be particularly significant for many of our patients, there's a huge risk of what we call collateral damage. This means that our children, our patients, are going to have difficulties in accessing regular pediatric care in the setting of COVID. They're not going to necessarily be able to get their essential medicines, the supplies, and the medical care that they need to survive, to get better, to get a cure from cancer, or to receive treatment that they need to be healthy. In Italy, there was a 70 to 80% decrease in pediatric presentations to hospital during the height of the pandemic in April. And at that time, there was a study that I've referenced here that was published in the Lancet Child and Adolescent Health, which noted that there were 6 children who were admitted to ICU and 4 children who died. So more children than died of COVID or other complications of COVID. Actually, children died of things like DKA, delayed presentation of ALL, because their parents were hesitant to bring them to the hospital, or because they couldn't access the care because the hospitals were overwhelmed with COVID. And the family is very impacted in the setting of COVID for these seriously ill children. There's the disruption, like I've talked about, of these usual support systems and care that they get. They might not take the nursing care or the caregivers or the volunteers and allow them into their home to help with the care because they're worried. They're very afraid. They're very anxious, these parents. And they may decide not to go to hospice or not to go to the hospital because they're fear of getting COVID or their child getting COVID. And we have seen this in many, many patients that I care for in Ottawa. They're very, very anxious about COVID. They know their child is very vulnerable, and they're very scared to bring them for routine care. The other challenge we have is accessing PPE. These children need more PPE. They need to be protected. They need running water for hand washing or access to things to allow infection prevention. And these can be hard in resource-limited settings to access, and for parents who are poor. And we need to plan for the situation that what if the parents get COVID? What if the parents are ill? Who will care for these children? Because many times the family cannot care, like the extended family. And this happened in China, a child with severe neurological impairment. The father was quarantined for COVID and nobody cared for the child because they didn't know this child had serious problems, and the child actually died, not of COVID, but died of neglect. So this can happen. We know a little bit about how we should care for children who need symptom management at end of life if they do have COVID. So I'll draw your attention to this link, which is the briefing note from the International Children's Palliative Care Network. I worked on this with a number of my colleagues to provide a comprehensive overview of how we should manage the symptoms of children who have COVID. We should focus on comfort. That's the goal of palliative care. If children are coming to the end of their life, we must make sure we comfort them. We must make sure they're comfortable, their symptoms are relieved. Because we know that untreated symptoms have such an impact on the child. They have suffering and distress. Their family, parents who watch their child suffer and die, have a lot of distress. They have PTSD, they have complicated grief. And we can prevent this with good palliative care. We can reduce their grief and bereavement. We can support them so that they don't end up in this situation. And we also know that good palliative care and treatment of symptoms prevents our own burnout as pediatricians and clinicians. Dr. Vishnu spoke about how we manage pain, and in the setting of COVID, it's the exact same. We use the WHO pain ladder, which has been endorsed by NAPCare as well. For step 1, if it's mild pain, we use paracetamol or ibuprofen, and step 2 is morphine or other strong opioids. And I draw your attention to this quote from the ICPCN statement. Evidence supports that appropriate opioid doses do not hasten death. Reassess dosing as child's condition changes. So we are not trying to cause them to pass away sooner. We are not doing anything to do that. Good pain control supports the child, whatever the outcome is, and does not cause them to pass away sooner. We know about how to manage cough and breathlessness, which is common in children with end-stage COVID disease. Pharmacologically, we would use oxygen if tolerated. Opioids are first line for symptomatic dyspnea in children at about 50% of the starting dose for pain. And second line is benzodiazepines. And there's lots of non-pharmacological measures which help: positioning, comforting, reducing anxiety. We just would not use a portable fan because of the risk of spreading infection and virus. Same as the idea of NIPPV, non-invasive ventilation, would not be recommended. And lastly, agitation, inconsolable crying, or delirium. So what we've seen in adults with COVID disease who are in ICUs, who are very sick, is that they are very agitated. They need a lot of sedation. So you may see a similar situation in children who have end-stage COVID disease. So we should look for and treat any reversible causes of such a situation, like pain or hypoxia, full bladder, or constipation being common ones. We must manage the environment, make it calm and familiar, have the parents present, have the child's objects like a blanket or a soft toy, because the smell and the reassurance from that. And then we use these medications, haloperidol, levopromazine, or chlorpromazine. And all of the medications I've mentioned are available freely in this Pediatric Palliative Medicine formulary, which you can download. Oh, sorry about this. Okay. So then if we look in more detail at palliative care during a pandemic, there's a very good article that came out in February of 2010, which talked about the need for palliative care in a pandemic, called Palliating a Pandemic. All patients must be cared for. And this article, they've published sort of an update this year, which talks about in the event of a pandemic, the key principles of healthcare planning is that all patients must be cared for. So we cannot abandon the patients we cannot cure, the patients who need palliative care, who are dying. We must care for them. We have to allocate scarce healthcare resources. The systems may be overwhelmed. We may have to triage and decide who gets care in an ICU and who doesn't, but we still must care for those patients who don't get a ventilator, who may be seriously ill. And we can use the ethical principles to support those kinds of care decisions. I'm not going to go through all of those today. Other considerations about providing palliative care during COVID. We found that there's much diminished interactions between staff and family, and this is a loss of support. Our presence is therapeutic for our patients and families. And if we are not able to visit them as much, to be present with them, they don't feel as supported. We can address that through virtual visits and virtual care and frequent phone updates. And we've been doing that with many of our patients. We can see in COVID that there are family clusters of critical illness. First, one family member is ill, and then it spreads to 3 or 4 other family members. And there might be multiple losses, multiple deaths in one family. So there's a huge need for bereavement support, both for the family and also for us as staff as we go through the process of caring for these patients. And here's a little bit of an idea about a palliative care pandemic plan.
Last minute for you to wrap up this.
Thank you. I won't go over this. I'll let you read this on your own. I want to talk lastly about some of our own stressors during a pandemic. Sorry, these are not coming up right. So we have the stress of seeing children die or have serious health problems due to delays in care from the lockdown or the pandemic. We may have to work in areas where we're unfamiliar or have a very high workload. We may watch patients die with uncontrolled symptoms, be unprepared for how to support them and treat them. So we have to care for ourselves. And that's why you're here today learning more about how to provide this type of care. And lastly, we know that all children are affected by COVID because children are in this pandemic with us and they are stressed. They pick up on the stress of us as their parents and caregivers. There may be job loss from parents. Parents may be very worried about COVID, or there may be bereavement, there may be loss in the family. Also, we know that children are home more, they're not going to school. This disrupts their routine, but they're also at risk of exploitation, violence, and abuse because they're not being seen by all the people who usually care for them, like teachers and other healthcare providers. Children may be separated from parents or lose parents or family members, which are huge risks. And we as pediatricians can advocate and ensure that the safety and health of all children is maintained, especially those who are most vulnerable. We can use the briefing notes from the ICPCN that I mentioned to create awareness and to help with guidance. And these documents are there to help you when you go and you want to speak to healthcare leaders, to political leaders, to advocate for the needs of children during COVID. We can advocate and reorganize the care for children with serious illnesses. We can apply those core pediatric palliative care principles, quality of life, reducing suffering, and supporting the whole family. And we can make sure that our patients have all the medicines and essential supplies they need. So this is one thing that we found in India was very important, was making sure if the families went back to villages and rural areas, they had the medicines that the child with the serious illness would need, like the anti-epileptics and morphine, because they weren't available in the villages. So you have to develop a system for how you'll get those medicines to the children and families. And lastly, as Spandana mentioned, we can provide information to children because we're pediatricians. We're good at talking to children. We know how to share information with them. And I love this graphic from the Harvard Health Literacy Project, which shows about how you talk to children around 6 years of age about COVID. And there are many other documents like this. And I will finish with this quote from Dr. Wendy Harpham. The greatest gift you can give your children is not to protect them from change, loss, pain, or stress, but the confidence and tools to cope and grow with all that life has to offer them. And so that's our challenge as pediatricians during COVID and as pediatricians who provide palliative care, that we can't protect these children from the serious illnesses that they experience or the COVID pandemic, but we can support them with the tools that they can help to manage this experience that life has for them. Thank you very much.
Thank you, Dr. Megan, for nicely covering the palliative care during COVID crisis. So we almost come to the ends, and we are going to present two case scenario with the discussions. So for that, I want to invite Dr. Sonny Sipai. He is a pediatrician currently working in pediatric hematology oncology unit, Kante Children's Hospital. He is dedicated toward patient care and has unique bonding with every child he takes care of. He is one of the candidates aspiring his future in pediatric oncology and palliative care. And the case discussion will be moderated by Dr. Peter Lewis. He is our mentor for pediatric palliative care for NAPCare. He is a pediatric palliative care physician from Vancouver, Canada. He worked at Connaught Place Hospice, in first pediatric hospice in North America. For the past several years, he has been involved with the Hyderabad Center for Palliative Care, helping in education activity, mentoring fellow, and training in pediatric palliative care. He is one of our main international mentor for Nepali Association Palliative Care to develop pediatric palliative care in Nepal as well. The floor is yours, sir. Sunny, for case presentation and moderation by Dr. Peter, please. Dr. Sani.
Hello.
You're
Yes.
audible, sir.
No, I couldn't share my screen. Can you help with that?
Dr. Chuck, can you help him?
Yes, hang tight.
Thank you.
Thank you. Today I'm going to present two case scenarios. One is associated with oncology, and the other is non-oncological case. Let's start with the case presentation. Here is the first case. Next slide, please. The first case is female, a 9-year-old from Rautahat. She presented to us with dull aching pain over the right side of abdomen, over right hypochondrium, lumbar and periumbilical areas, with a distension of abdomen for 2 months, associated with a loss of appetite and weight loss. On examination, she was very thin built with for abdominal examination. The findings were globular mass palpable at right lumbar, lumbar extended to periumbilical areas, margin ill-defined, smooth margin, non-tender, and was not moving with the respiration, but a bowel sound were present. Next. In a past history, it was not significant. Family history, previous slide. The family history, there was no any significant illness in the family. There was no any associated TB or asthma. On psychosocial history, the father was farmer and mother was housewife. They were from a very low income family, facing a very hardship in the financial issues. They had the girl has one younger brother who were in care of her grandparents, and they were Hindu by religion. They had no any insurance or any other support, so they were treating their children out of their savings, which was gradually adjusting their savings. Next. With all the findings and the investigations, the differentials made were the neuroblastoma, abdominal tumor, lymphoma, and leukemia. And we had sent investigations. Next slides. In the investigations, the ultrasound of abdomen showed the large solid multiple heterogeneous mass with the counts of 31,000 with neutrophil predominant, and ESR was 77. The AFP per sputum was negative, but CT scan abdomen was suggestive of tuberculosis or neuroblastoma with the findings. And the MON2 test was done, which was 10, and the doubtful. But so with the doubtful CT scan, whether it was tuberculosis or neuroblastoma, we had an biopsy which was suggestive of tuberculosis. So the final diagnosis made was tuberculosis. Next slide. Initially when there was a dilemma in the diagnosis, we was just started with the pain management with the paracetamol, and for abdominal distension we gave antacid and few antibiotics. As the family was from the poor background, the hospital had arranged for the fooding for the children and one of the parent, and some supports for the treatment from the social service. However, no any other counselor or play therapy was involved during the initial treatments. Next. After the final diagnosis, anti-tubercular drug was started, and there are a few things that we would like to discuss with the case, is presented in the next slide. Like we had trouble with the interdisciplinary coordination, as there was dilemma during the consultation, as was it tuberculosis or was it some sort of abdominal mass, as the CT suggests, had it been a neuroblastoma or other lymphoma. So that was a bit interdisciplinary coordination was difficult. With the nutrition issue, child was very thin built with a huge weight loss, so that was other issues, and we think we can increase the future plan by increasing the interdisciplinary coordinations and taking care with these things in the future.
So thank you, Dr. Sani, for to summarize very quickly. This is a 9-year-old female presenting with 2 months of abdominal pain and decreased appetite and weight loss with the ultimate diagnosis of TB with a family which had exhausted their savings in seeking medical care. And this is a important and interesting case because often in palliative care we think of cancer diagnosis, and in this case we would consider this a category 1 illness, which Dr. Sidir had mentioned earlier, where it's a potential treatable condition but has a high chance of, or a good chance of mortality, or a good chance of failure. And so many times we don't think about infectious causes as needing palliative care. And it seemed like in this scenario, it must have been very difficult for this 9-year-old to face, to be so ill and have so many investigations and seeing their family very stressed and also having pain and discomfort. So I'm wondering if I could ask Dr. Spandana, because she was talking a lot about communication, whether she could expand a little bit in terms of how communication or working with the rest of the team could have added to support in this case.
Thank you, Dr. Peter. So this is a very interesting case. Thank you, Dr. Sani, for sharing. And I was also thinking what would be going on in a 9-year-old's mind, especially when we are not sure yet of the diagnosis and families spending all the money. And they would want information, and we would want to protect them from all the information. So I was thinking, even how do we even begin talking to this girl? 9-year-old, they're not at our height. I think that is the first thing we have to remember in pediatric communication, that we have to be at the same eye level of the child. We cannot be standing and they cannot be standing, and the eye level is different. And whatever information we give this girl has to be age appropriate and also appropriate to her developmental needs. So when we start talking to her, we realize what is her understanding of what is happening. And one thing I think we all will agree is that never lie to the child, always be honest. And repetition is the key in pediatrics. Sometimes a single time when you tell her that this is what is happening with you might not sink in. So sometimes having to repeat the conversation, which is not something we do a lot of times with adults, but in pediatrics is helpful. Also, a child like this can ask questions when their parents are not there, because she is more curious about what is happening, but she also wants to protect her parents. So she will ask, once the parents leave, she'll ask the nurse or the doctor, "Doctor, what is happening to me?" Or "Nurse, what is happening to me?" And it is very important that we do not shut down a conversation there, and we have to ask questions like, what do you mean? Why are you asking this? What do you understand by what is happening to you? So I think these are few things we can start by, but the most important thing is listening to the child. So always listen to what her concerns are. Sometimes she can say things like, "Am I going to die?" Or sometimes she may say things like, my parents' money is all over. What do we do from here? So I think, Dr. Peter, I'll stop here and hand it over to you.
Thank you, Dr. Spandana. We can move on to the second case, please.
Thank you, Dr. Spandana and Dr. Peter, for a nice explanation. Now we go with the second case. Next slide, please. The second case is a male child from Jazarkot, 12 years old. He presented with a pain over both legs for 1 month, with the abdomen distension for 1 month, weight loss and loss of appetite. The child was also thin-built with few petechiae over both legs. There were bony tender, but there was no any swelling. with the poor abdominal findings showing a palpable liver and spleen with normal bowel sound. Next. Child was had no any past history of any medical illnesses. There was no any family history with cancer, TB, or any other issues. Uh, According to the psychosocial, the father had been to foreign in India for the employment, whereas the mother is a housewife, and they are also from a low economic family. They had two other daughter and one younger child, and they were Hindu by religion, and they had no insurance, health insurance, and they were treating from their savings that father bought during the foreign employment, though they had hardship during the treatment of the child. Next slide. Concerning about the communications, the family were worried about the prognosis and treatment of the child. The psychologist was involved during the counseling, whereas fooding and lodging had been arranged from the hospital. For other support, few treatments, medications had been from the hospital, whereas even the government support had been given for this child, as the final diagnosis made was leukemia. Next. With the differentials, acute leukemia, tuberculosis, and Kala-Azar, we go through the investigations. Next, please. The investigation shows pancytopenia with a total count of 3,200 and the hemoglobin of 6.5 and platelet 35,000. The peripheral blood smear shows 40% blast, and the bone marrow aspiration was diagnostic of acute lymphoblastic leukemia for this case. So we had a diagnosis of acute leukemia. For the pain management, we had started with the paracetamol, and then we moved on to the codeine tablet for the pain, but it was not helpful. So we had started a morphine in SS. We had a very poor experience with the morphine, so we were a bit hesitant to start morphine regarding its side effect and the other issues. So we had a bit trouble, and we were hesitant to start the morphine for this child for the pain management. But later, with discussions and consultation with the other expert, we finally started round the clock morphine for the pain management. With that, later the child did well with that. So we had a good experience to start work with the morphine during the management of this child for the pain. Next slide. So finally, the diagnosis was acute lymphoblastic leukemia, and the child was started on chemo with the pain management from morphine that causes gradual improvement in the child. Next. The things that we had issues with this child was the pain management in the child and the analgesic drugs use. We were very, it was difficult for us to start with morphine, but we were not much experienced with use of morphine. After only consultation with other expert, we started using morphine, and the issues was with also communication regarding discussing the cancer and what was the issues and how we could go with the treatment. So I expect Dr. Peter to go more with these things.
Thank you, Dr. Sani, for your case. And to summarize this case, it's a 12-year-old child who presented with mostly pain in the situation, who with a family which had low income and financial difficulties, and was ultimately diagnosed with acute lymphoblastic leukemia, and finally to be able to achieve good pain control on morphine. And with Dr. Vishnu's talk, we could see that with the availability of morphine and its use and to know how to use it and dose it is extremely helpful for children like this. To make a comment on codeine, often in children, we don't use codeine because what happens with codeine is it's converted to the active ingredient morphine, but then it also has multiple metabolites, which cause a lot of side effects. There are some people whose liver doesn't process it properly and the morphine doesn't work, and other people, especially in children, who process it too quickly, and then it results in a huge release of morphine, which causes respiratory issues. So at the end of the day, if we're wanting to use a morphine type medication, rather than codeine, we would just use morphine so that we know exactly what we're dosing. I wanted to ask if anybody in the chat has any comments about morphine or morphine dosing or questions about that that we could ask our panel. Does anybody on the panel have any further comments about opioids or about pain management?
Yeah, Dr. Peter has nicely said that, and then I talked in my talk also that the pain is very common. In fact, in those two cases we presented, the presenting symptom were pain, and now, at least in the second case, they learned by themselves that codeine is not useful and the morphine is useful. So we should have to develop a system when the child comes with the pain to at least assess and try to categorize how severe is the pain, what type of the pain, and depending upon that WHO two-step ladder, we should not be reluctant to use morphine. As I fully agree with Dr. Peter that morphine is a wonderful drug, and in our hospices, nurses are using a lot. And whenever the child goes with the pain in the hospices, they use it and child gets relief. In fact, in my whole career, in my oncological career, I really feel happy when I see a child suffering from pain after taking morphine get relief. That's the biggest reward I consider myself. I got it compared to all national and international awards. So I encourage all our colleagues to use morphine judiciously. And Dr. Megan has also already said that we can use morphine. Morphine is available. So whenever needed, please use it. It really helps the child.
Thank you. So Dr. Krishna, I hand it back to you.
Dr. Krishna? Dr. Krishna sir? I don't know if he has. So maybe, sorry, it looks like he is disconnected. Maybe I think we have completed the sessions. So I will, as a president of the NAPCare, Nepalese Association of Palliative Care, I like to thank our international panelists, and I like to thank hosting and our Pediatric Society, the president of Pediatric Society, Dr. Krishna, and all participants for participating and making this session useful and fruitful, and hope in the future also we will try to organize like this, maybe a shorter, like something like a pain management or morphine or opioids, maybe shorter. And we expect help again from our international faculties and from the Nepal. So I'll, with the thanks and apology for being a slightly delayed because of technical things, I want to conclude the session. If anybody has anything to suggest, otherwise I'll conclude with the big thanks. Thank you very much.
Thank you, sir.
Thank you, everybody.
Yeah, special thank goes to Dr. Sudhir, who is the man behind this all. He has been working day and night. In fact, I don't know how many nights sleep has gone. So Dr. Sudhir, you deserve special thanks.
Thank you, sir. Thank you. Thanks a lot. Actually, I'm not doing extra. I'm just a part of a team, and thanks to all of us for this great team effort.
Okay.
Good night to you, Peter. Good night to
Great
everyone
talk.
in Canada. Hope we'll be organizing such programs further in future and hope to get more participation in coming days. Thank you all.
Okay, thank you all.
everybody.
Bye.